Hi, I'm Dr. Rajiv. I'm a consultant nephrologist from Kim Sunshine Hospitals, Paradise, Secunderabad. I've been a nephrologist practicing here for the last 9 years. I've done my MBBS from Usmania Medical College, my MD in General Medicine from Nizam's Institute of Medical Sciences, and my DNB in nephrology from Medicity Hospitals, Hyderabad. So the topic for today that I'm discussing is edema, which is one of the most troublesome problems that we have in nephrology, and it is something that people from various specialties face on a daily basis. And the problems that we face range from both being just troublesome and irritating and cosmetic. For example, you have a patient who has been on amlodipine and they have calcium channel induced edema, calcium channel blocker induced edema. And that can be quite irritating, but it's not really serious. On the other hand, you have a patient who is in the ICU who has pulmonary edema, and that's probably one of the most serious complications you can have from edema as such. But there is a whole range of problems that happens in between, and you have to deal with them as a doctor, as a nephrologist, as a hepatologist, as a cardiologist. And I just thought I would like to go through my approach towards dealing with edema. So it all depends upon what the cause of the edema is. The patient with nephrotic syndrome who wakes up one fine morning with edema is very different from the patient with cirrhosis of liver who has been having edema for a long time, or the patient with chronic heart failure who's been having edema for a long time. The way you treat all these things depends, because the treatment goal ultimately depends upon what the underlying disease is. For example, if you have a patient with nephrotic syndrome, what you tell that patient is, take a diet which is less in salt, but you would also put them on a diuretic. And these patients, with very few exceptions, can tolerate stiff dose of diuretics. And they do have very satisfactory diuresis if the primary cause of edema is sodium retention. On the other hand, if you have a patient with cirrhosis of liver and they have ascites and edema, and you put them on diuretics, most of the extra fluid, if you remember, is actually there in the peritoneal space. And this fluid cannot be mobilized easily by diuretics. And if you are taking out more than 500 ml per day, chances are that this fluid is coming from the intravascular volume, and you will find that these patients end up having hypotension, rise in serum creatinine, and other complications. Similarly, the patient with heart failure who is having edema and breathlessness, obviously you're trying to cause relief of their symptoms. But again, the other side of the coin is that these patients can often end up with hypotension, and sometimes that leads to, that is a result of their lowering of cardiac output, which sets off further problems down the train. So what is it that you can do to manage edema safely and effectively? First and foremost, think of the cause. Is this because of the disease itself, or because of some medication, or because of some lifestyle issue, or a combination of all these factors? Quite often you'll find that patients have a combination of all these factors. So you should address all of them. So with regard to lifestyle, you should have a clear idea about how much fluid you are supposed to be taking and stick to it. Salt restriction works in nearly every condition. So whether it is cardiac or hepatic or renal cause of edema, salt restriction is the cornerstone of edema management. And your diuretics are not really effective if, on the other hand, you're adding salt to your food while at the same time you're trying to remove salt from the body. The other thing is, you could try some simple measures like elevating your limbs. This kind of pushes the fluid from the interstitial space back to the intravascular space, and your kidneys now have a chance to excrete this fluid. You could use compression stockings and all these other measures. These are very simple and they're harmless in nearly every situation. But when it comes to actual medication, again, you're spoiled for choice a little bit, but you also have to be very rational in what diuretic you pick and why. For example, if you're using diuretics in, let's say, nephrotic syndrome, you need a combination of mineralocorticoid antagonist like spironolactone along with loop diuretic. The reason for this is that the loop diuretic will remove fluid very satisfactorily, but will also dump a lot of potassium out of your body. And the spironolactone, one, it tackles the RAS chain further down the line. Plus, it also counteracts some of the potassium that is being lost by the loop diuretic. So that's quite a satisfactory combination to have in nephrotic syndrome. In cirrhosis of liver, as I said, you should be weighing your patient almost daily and seeing that they don't lose more than 250 to 500 grams of fluid per day. And you should have a clear idea of when you're going to back off the diuretics, because if you keep diuresing them beyond a certain point, they're going to end up with azotemia, they're going to end up with metabolic alkalosis. You can precipitate hepatorenal syndrome in them. A lot of other complications can happen. Similarly, in heart failure, the combination of loop diuretics and mineralocorticoid antagonists works really well. Aldosterone antagonists like spironolactone, eplerenone, they have other benefits other than just helping remove fluid. They do prevent remodeling of the cardiac muscle, which is an important reason why they have mortality benefits. So there are other things that you should be doing, like avoiding painkillers like NSAIDs, because these drugs have an effect which is diametrically opposite to what your diuretic is trying to do. Because these drugs tend to trigger mechanisms that retain salt and water in the body, which is, again, opposite of what you want to achieve. So the ultimate goal of edema is something edema management is something you should be very clear about. So it cannot be that in every patient you expect them to have pristine edema-free legs, because while trying to achieve all that, you may push the patient over to the other side where they end up with complications related to the use of diuretics, which is something you don't want. There may be a point where you're satisfied with a little bit of edema, but you've met your clinical goals. If there are offending drugs, you should always replace them. So if you have, let's say, amlodipine causing edema, sometimes switching over to something like cilindipine does help. But while they are waiting for the cilindipine to show a more beneficial effect, they might benefit from a short course of diuresis or the use of diuretics. And again, it depends upon how intense a diuresis you're looking for. So patients with renal failure tend to require higher doses of diuretics, mainly because lower doses of the drug don't reach the tubules. And you may need to piggyback the drug onto something like IV albumin when a patient is in the ICU and they're having pulmonary edema and they need diuresis. So the albumin actually carries the diuretic to the loop of Henle where the drug is effective. So these are all small tricks that you can use to make your diuretics more effective. But the biggest and the best thing you can do is to treat the underlying cause of edema in a systematic way and try to prevent edema if possible, because it's always more difficult to treat edema rather than prevent it. The body has many mechanisms to counteract whatever you're doing when you're trying to treat edema. If you remove some fluid, it will trigger all kinds of mechanisms that try to retain sodium and water. And again, you end up fighting those, and sometimes they are more powerful than your drugs. So it's always better if you can help your patient avoid landing in that state. But edema management is a very refined art. But there are the cornerstone principles are what I've talked about and should be applicable in every situation. Thank you.